The webinar will now begin.
Hi, everyone. I'm so excited to see so many people attending tonight's webinar, which is a partnership between the American College of Medical Genetics and Genomics Student Interest Group and the National Coordinating Center for the Regional Genetics Networks, who host Public Health Genetics and Genomics Week. My name is Megan Lyon. I am the co-project director of the National Coordinating Center for the Regional Genetics Networks, otherwise known as NCC, since it is a long name. And NCC is a federally funded program that is run out of ACMG. We've been funded by the Health Resources and Services Administration since 2004 in different iterations, but really our work focuses around improving access to genetic services for underserved populations. And that's why we take a public health approach and we look at genetics and genomics issues and barriers to access through a public health approach. And over the years, we've expanded our scope. Both the NCC and the 7 regional genetics networks have expanded our scope to be looking at public health genetics and genomics through an individual's lifespan. And through those discussions, we really saw the need to raise awareness about the field of public health genetics and genomics, as this is, for some individuals, you may not feel like you work within either public health or if you are a genetics provider, you may not feel like you're doing public health. If you're in public health, you may not understand the genetics aspect. And so we really wanted to bring together the professions and the individuals who are part of public health genetics and genomics and receive services through public health genetics and genomics programs to raise awareness about the field. So every May, we hold Public Health Genetics and Genomics Week, and we hold a host of events to really tailor education and awareness about the field to different audiences. And so we are absolutely thrilled tonight to have you all and to be talking about the role of geneticists in public health genetics and genomics. And shortly, I'm going to ask the speakers to turn on their video and join. But as I'm doing that, we do have a brief poll that we would like everyone to fill out just to understand the perspective you're coming from. So if you don't mind answering the question of what your professional type is, we'd appreciate it so that we can ensure that this is an open discussion. We do not have the slides. This will be just a conversation between myself, Dr. Bedertha, Dr. Bloom, as well as you all as audience members, and get your questions answered about the role of geneticists in public health genetics and genomics. And so we really want to see who's out there with us tonight as we get started with our discussion. And I see that we have, looks like most people have participated. I will give it maybe one more minute, or I turn off the poll and share results. But as I share results, Dr. Bedertha and Dr. Bloom, if you don't mind turning on your cameras so we can get started with our discussion, I would appreciate that. And as I said, this is an open discussion. So we have some discussion points between the three of us that we'll address, but we want to hear from you all. So please, please, please feel free to chat your questions, to put in the Q&A, to raise your hand. We want to make sure we're answering your questions. If you are watching this as a recording later on and you come up with a question, please feel free to reach out to NCC. I'm happy, we'll provide my email address and I can field the questions to the appropriate speakers, or follow NCC on any major social media platform and you can DM us with your questions as well. And so with that, I will end the poll and share the results. I think everyone should be seeing it. Yes, I'm seeing Dr. Bloom says yes. So it looks like we have a really great variety of people joining this webinar. So it's great to see medical students, graduate students, undergrads who may be interested in the field, as well as residencies and some genetics providers, as well as public health professionals, which is my background. So it's always great to see public health professionals as well. So with that, I will start with my first question, just ask our two speakers to introduce themselves. So first, I will ask Dr. Bloom, can you tell us a little bit about yourself and your journey?
Hi, Megan. Thanks for inviting me to participate this evening. Want to say hi to everyone in the group. So right now I am a research scientist at the University of Pittsburgh. And I'm happy to tell you a little bit about my career path and how I ended up in the role that I'm in right now. I completed my bachelor in biology at Wilkes University, which is in Wilkes-Barre, Pennsylvania. And once I completed my bachelor's in biology, I decided to go right into graduate school. And I went to the Graduate School of Public Health at the University in Pittsburgh, which is in Pittsburgh, Pennsylvania as well. So I just crossed the state. And I was able to kind of come to this decision because spending my time doing some laboratory work and just gaining more knowledge in the biology field, I knew I wanted to dive deeper into research specifically. And my advisors and mentors had guided me and kind of let me know that the best way to do that was to look into graduate school, specifically in public health. So I got my PhD in in human genetics at Pitt. And when I finished graduate school, during that time, I became interested in inborn errors of metabolism specifically, and kind of just the clinical side of looking at these various diseases. And so I decided to pursue a fellowship at the University of Pennsylvania, which is over in Philadelphia. So I decided to cross the state again for 2 years and worked in a laboratory there, which the fellowship program is actually called clinical biochemical genetics. And it's offered through the ACMG, which is American Board of Medical Genetics and Genomics. So I received certification there in clinical biochemical genetics. And then I pursued a postdoctoral position back at the University of Pittsburgh. There's a theme here. So back across the state again, and started out working in a lab there with Dr. Lisa Pan. We were actually working on a kind of a neuropsychological and metabolic study. And I transitioned into a role in my current lab right now with my mentor, Dr. Jerry Vockley. And I'm working in his lab, which is again part of the University of Pittsburgh. It's actually a lab that's located in the Children's Hospital in Pittsburgh. So I have different roles there in that lab, which I think we'll get into a little bit later. But that's kind of how I came into my role as a research scientist.
That's wonderful. And it sounds like you have great knowledge on Pennsylvania and different places to go in Pennsylvania as well. So Dr. Berger, do you mind introducing yourself?
No, not at all. It's great to be here, and it's a privilege to be talking and interacting with all of you in Public Health and Genetics Genomics Week. I was born before newborn screening was a thing. So when we think today of all the benefits of that, one of the top 10 public health achievements of the last century, et cetera. I guess for those who might be, a generation before that, again, be proud and pleased that you had the benefits of newborn screening. I go fairly quickly, grew up in Connecticut. My mother didn't go to college, so again, I really didn't come from a medical family at all, but had great teachers. And again, I think, really choose your educational places where you'll get good teaching, and it's not always about reputation. I'm actually a medical geneticist at Johns Hopkins now, but to the extent that it was never about, it was really always about having good teaching and mentoring. And that included, in high school even, and all. Went to Swarthmore for college, and by the end of, I thought I was going to be a math professor. By the end of 2 years, it was down to me, 2 guys, and a little Wang computer in that day, and I realized I was more social than that, and then had the benefit of having a professor in genetics. John Jenkins wrote one of the textbooks that's used in a lot of undergraduate classes still, and then realized again that I didn't really know much about medicine, but he encouraged me to think about medical school. And back then, Yale didn't realize that you could get an MPH without paying for a separate degree when you were getting an MD, and you needed to do a thesis for both. And college was very supportive, and I had a LUCE, as in LUCE, not LOOSE, fellowship. So spent my third year of medical school at Nagasaki University School of Medicine, looking at red cell membranes in muscular dystrophy carriers. And we didn't really have DNA. I'm not older than DNA. I'm older than newborn screening, but DNA has been around a long time. And so basically in medical school, did rotations at Children's Hospital. I had a little $500 March of Dimes summer scholarship and worked in a lab looking at not only pedigrees and neural tube defects, but also a glucuronidase assay, which people thought might be related to cystic fibrosis. So one thing I'm telling you is be prepared to learn lifelong and change, because things that are taught to you by very smart people will change. Also did a rotation at the CDC with Godfrey Oakley in the birth defects branch, and also at NIH, and really got to meet some of the people that wrote the chapters in all the books and that sort of thing. I did have a public health service scholarship for medical school, so I had a 2-year commitment, and went to the Indian Health Service in North Dakota and did everything there. So geneticists who are medical geneticists do see conditions in people and families across the age span. And I would not claim to be an internist. I would not ever say I'm really a great family medicine doc, but to the extent that having that experience, I think, was really helpful. My husband, who is also a physician, hematologist, oncologist, and I had already looked at fellowships before we went off to the Indian Reservation and went back to what was then MCV, now VCU in Richmond. And so my experience at that point had been, I would say, university medical centers for training, but then either federal or state institutions. So I was always having to think in some way about service and resources and how we managed to do things, across a Native American Turtle Mountain Reservation for 7,000 individuals for the state of Virginia when we were in Virginia, and now here at Hopkins, back at a really wonderful institution for training, mentoring, and lots of experiences. So I think things that were seminal in my development, my dad had cancer when I was growing up, and so I was always interested in cancer. I think I was also interested in lots of good mentors in sort of why I was shorter than my brothers by the time I was, they were like 2 sort of thing. So things like height and differences in people in fellowship. I had, again, a great chair, Walter Nance, and took a week, each week in my first year of fellowship, I looked at eyes for the week. And then the next week I looked at noses, and the next week I looked at ears and stuff. And believe it or not, had a paper on fingernail length. So if you ever want to know about normal fingernail lengths in newborns, you can look up the Vidurtha et al. Paper that I did with a medical student. So I think, again, a little bit about myself. Do have a daughter who is actually a physician as well, but I think have just really always benefited from great teachers who are willing to share and enthusiasm about what I do, which I still love.
That's wonderful. And I think you both touched on a point that I think is critical, and I'm sure the students who are on the call and the professionals who are past the student level can agree with, is that mentorship and having leaders really helps you advance your own career and understand where you want to go as a career. And that's one of our hopes from this webinar, is to show you all kind of what a day-to-day looks like and what you can anticipate from working as a geneticist. And so with that, Dr. Bloom, do you mind telling us a little bit more about what your day-to-day looks like?
Sure. So in my role as a research scientist, my day-to-day is pretty flexible. So right now in my lab, I'm the main project manager for about 2 to 3 different studies, which they can change over time. But I'm working on 3 different studies. One of them is actually looking at a therapy for PKU, or phenylketonuria, in a pig model, working with Nestle Health Sciences and Tufts University in Boston. I also do the bulk of the functional testing, or the different assays we have available in the lab, to different cell lines with all different conditions that are sometimes from in-house from our clinical lab and working with patients that we see in clinic, or from collaborators that send us cells. So I manage most of the testing of those fibroblast cell lines. I also manage our tissue and cell culture facilities. So taking inventory of supplies, managing the cell database, just kind of keeping everything on track with all the different members of the labs in that regard. And which kind of includes just some kind of maintenance and day-to-day chores. If there's a piece of equipment that goes down, I'll take care of that, contact the company, coordinate the shipment of that instrument out, or bring service company in to take care of that equipment. So I have some flexibility with, experiment days, maintenance days, as well as just kind of orders and supplies. So it varies. I have different roles there, but my main focus is typically the research projects and what needs done to keep those moving and get things completed.
That's wonderful, and I think a lot of us can understand balancing roles. So it's really interesting to hear how you go from research to the maintenance side and all that is in between. And what about you, Dr. Baderza? What does your day-to-day look like?
Yeah, I would say there is some, what's the right word, a little bit of a schedule, but each day does still feel different and a bit of an adventure. With electronic health records and all of the, changes in connection and shared decision making, et cetera, I really start my day with looking at Epic and seeing what staff and patient and other messages I have, and trying to make sure they're addressed as much as possible in the morning. And those can range from, I saw you 10 years ago and I'm still, not diagnosed, and sort of getting people connected to Undiagnosed Disease Network or seeing them in clinic, to, basically I spent half the day on one of our clinics that we do through a federally qualified health center in Salisbury, Maryland, on the Eastern Shore. Again, not only my Turtle Mountain Reservation experience, but again, I've sort of like to not only handle the individual, but handle the broad. And so the idea of being co-director of NIMAC, one of the regional collaboratives that works very closely with Megan, again, is that we developed a program, I think 7 years ago or so now, where I am available for initially phone communication, now teleconsults with the medical doctors there, primary care providers in a rural area. And again, we do everything by telehealth. So I see essentially children from there. We had a Haitian Creole interpreter for the last patient of the afternoon, who clearly has a significant intellectual disability as well as autism, and sort of arrange for testing. He also happens to have renal tubular acidosis, so we're working with nephrology. And then a couple of other patients who, again, one has hearing loss and the other, again, was more around obesity. So that, you're sort of connected in the office and screen. I typically will have undergraduate students with me for telehealth sessions and in-person sessions. I have the medical students and residents and all. The other parts of my day today were around beginning a study. We're looking at the importance or not of family history, genetic consultation, and genetic testing in pediatric mortality as part of quality improvement, which again is sort of another path that geneticists are thinking more about. We have 100% mortality review as one of our goals as a hospital system. And so we have a student project, a tutorial project that's actually called Genetics and Public Health Tutorial, where a team of public health students, nursing students, undergrads, residents, there are faculty involved in this one as well, are really trying to see what the benefits or not of more detailed family histories, genetic consultation are in not only understanding more of the causes of childhood mortality, but also seeing about that follow through that's so much a part of public health, of seeing what's going on in the rest of the family, because, you know, I think most of you, you know, have your square, you know, your Punnett squares down to know that if we identify a recessive or dominant condition in a family, depending if it's de novo or recessive or not, then siblings are potentially at risk. And so we don't want, if we're dealing particularly with mortality, we don't want another child in the family to die because we didn't extend, whether through cascade testing or bringing the family in that. So I feel like I'm making always the connection of the dots to public health programs and teaching that then feeds into thinking with genetic antennae up.
Well, I think that that's a great segue into my next question. And you both have already touched a lot on things that you do within public health genetics and genomics. And that I think you both exemplified the wide breadth that public health genetics and genomics covers. But when is there anything you want to expand upon in terms of your involvement with either public health genetics and genomics effort or program? And I'll start with you, Dr. Bloom.
Yeah, I wanted to bring up a point about the importance of newborn screening. So I guess aside from my career path, one of the other avenues I had to become interested and involved in public health genetics and also metabolism specifically was, unlike Joanne, I was around when newborn screening was being conducted. And that was very fortunate for me because I was actually identified through newborn screening as having PKU or phenylketonuria. So having that and just working through that on a personal level has fueled my interest in public health genetics and genomics, and it kind of continues to help me make that connection or that bridge between you know, the different disease populations or individuals we might see on the clinic side, and just how the research side can have such a positive impact that would go right back, you know, feed into that clinical population of patients with, you know, a variety of different diseases and conditions. So I think I have a pretty unique situation when it comes to that aspect of how you know, life ties into my career choices.
Yeah,
absolutely. And I think that you just really hit the nail on the head about how it is a system that public health genetics and genomics is bridging. It's trying to bridge the research with the clinical side and make sure that anyone who needs the access to the services are getting them. So I think having that perspective is, I'm sure, very unique and it has helped you well. And so, Dr. Bertha, what about you? What does I'm sorry. I'm used to calling you Joanne, so I apologize. What about you? What does it look like your involvement for public health genetics and genomics program?
Yeah, I mean, again, I had a number of leadership positions along the way, and I guess I'm going to just throw in about advocacy. And again, kind of thinking back over things, I remember when a person who will not be named, but a chair of pediatrics relatively new at VCU, came in and didn't think we were making enough money from a state grant for newborn screening and wanted VCU to drop out, or MCV at the time, drop out of newborn screening. And I remember really, you know, having to strongly advocate the case that we should continue this, that at that point we were covering what was going on at King's Daughters because they lost their geneticist. UVA obviously is a great place, but UVA really wasn't prepared to cover the whole state for newborn screening. And then I guess it was a little before that, when sickle cell newborn screening was discussed, there were people in the state who really thought it should only be done in what were termed Black people and all. And I remember not only having the experience of having, you know, classic non-Black or, you know, in old terms, and all folks who had sickle cell and certainly were sickle cell carriers, and standing up to just say, no, we you know, if we were going to start hemoglobinopathy screening, it needed to be everybody, that wasn't the way. And some of that was based on my knowledge, and some was on a sense. I don't know that I always had a, you know, I certainly didn't have always a deep understanding of when things challenged me ethically, but I knew something didn't feel right about that, and it's important to do that. And then just remembering another time, because we started the LEND, or Leadership Education Neurodevelopmental Disabilities Program, which is another HRSA-funded program that works toward access of children with complex conditions, some genetic, but not necessarily genetic. And there was no real connection, even though 5 of us were geneticists who were LEND directors, between the funding, and there was no outside federal funding for genetic counseling students. And so I remember having coffee with people from HRSA at Union Station, saying there needed to be genetic counseling needed to be added as a discipline, and medical genetic fellows. So the fellows we had at MCV could do the LEND training and learn again in multidisciplinary clinics and from other disciplines, as well as the genetic counseling student, at least get some of their coursework covered. So those are, personal advocacy things, but I just think that's another aspect in which, again, and the research is obviously so important, but advocating for research is another part, I think, of what we do. So I would sort of add advocacy and policy development. And certainly that's a strong interest of Megan's and the work that you're doing.
Yeah, and I think that lends itself next to my next question very well. Of really, what considerations do you all, as geneticists, take into account when you think about populations versus individual? I think advocacy and thinking through what implementation looks like is a great example. But are there other things that you all have encountered that you really have to think through when you're looking at a population level?
I think mine goes back to just kind of like the newborn screening and the different public health programs that are available, and becoming interested in those programs, and just kind of opening your I guess interests to a variety of disease populations, and just kind of by just learning more, continuing to kind of develop a skill set and just kind of find out what you're most interested in. And there's a lot of different avenues to go about that you might not know about. So it's always important to, speak with mentors or teachers or leaders about, your interests. And I saw the question in the Q&A from John. So if you wanted to focus, towards genetics, my suggestion would be to speak, for example, to your advisors, or if you have a genetics department, for example, just find out who might do collaborations with the genetic leaders, at your university or institution, and just kind of go from there. Just kind of learning who does what, and using mentors and teachers as a really valuable resource could, kind of help you to get into that field, or just learn about the different opportunities that might be available.
Yeah, and I would offer up, I appreciate the opportunity to continue to see individual patients and families, and really there are policy and public health implications to every, piece of the system that people, whether it's through newborn screening or preconception screening, or all of what's going on across the country in terms of prenatal services and women's health. And then being able to impact that. I mentioned the policy already, but trying to continue to be thoughtful about policy. I have the good fortune of working with excellent people, again, including NCC, around workforce issues, because clearly sessions like this are designed to try to address your questions and have you see people who are still excited. And there are men in the field, even though we have a lot of women up on the screen. I want to be clear about that. It was certainly, mostly men when I started out. We had a founding mother or two of genetics, but it was more founding fathers. But again, I think the times have changed and are much more inclusive and all. But we are working on the inclusion across other, subgroups and populations, and that is something I think really enormous effort needs to continue to be, pointed in that direction. Again, looking at the first question in the chat, I would, in terms of depending on what, your capstone allows for somebody who is a combined MD, DO, MPH student, is really try to make the capstone something that does bridge those things, and all. For example, and you might create it at your place, because certainly that's, some of the current young leaders in the field are people who've done things starting as medical students and all of either helping to create a track, let's say, or something special, or making sure there's a SIG at their school or student interest group at their school, as well as one of the things that we do here at Hopkins, and again, it's with this group who are in the tutorial, is a table on family history awareness at one of our public markets twice a month. We also do health fairs in the community twice a year, and some of that is really just trying to build trust in folks who, whether it's all that's gone on with COVID, all that's gone on historically in genetics, don't think of genetics as friendly and all, or people to be trusted. But I guess my lived experience as well as professional experience is that the family is really important. So people come up to our table, we have handouts about different conditions. We actually now have a IRB survey just around sort of the importance of family history, how they would like it approached in their community settings. Have some invitations to talk at some churches coming up. And again, I always have students with me doing that. But again, depending on where you are and what a capstone is, I think, some is also finding then the people to support you in that at your school. We work collaboratively across the nursing, public health, and medical schools.
Absolutely, and I will take as moderator. I hope you guys are okay with that. I jump in and also say for capstone. So again, I work for the National Coordinating Center for the Regional Genetics Networks, NCC. We often have students, and most of our students actually come from the PIT program, because there is a specific MPH program in human genetics. They're one of 3 in the country. And so every year almost, if not more than one person, we have someone come in who's getting their MPH and do a capstone with NCC. And I know some of the other regions have had MPH or ND or DO internships, because as I know Dr. Bertha has discussed some of the work at NIMAC, what we're really focused on are those access tools and resources. And so it's bridging the gap between the clinical knowledge, the research knowledge into other fields or to other audience types. And so there's a lot of programs and beyond NCC in the region that are funded by federal and state governments that people often go and do their capstone or their thesis projects with. So I would offer that too if you're interested in pursuing that type of work. So with that, we've gotten a couple of questions in the chat, which is great. So I'll start with the first one of, after working for years in the field of genetics, what continues to fascinate you as a professional? Dr. Blinn, do you want to start?
Yes. So I think right now what's pretty fascinating is the number of therapies that are being developed for all different types of disease populations. I think that's really, really promising for genetic conditions that, maybe there's not a lot of information out there, or I'll use PKU as an example just because I have the most experience with that one. But for example, the therapy was a strict low protein diet for years. And over time, they've been developing different therapeutics, which are like, oral enzyme. They have an injectable enzyme replacement therapy. And they continue to develop more. And I can tell you from personal experience that it is a quality of life changer from when you have to spend 30 some years on a strict low protein diet, measuring your food and drinking medical formula, to injecting the enzyme under your skin as a sub-Q injection. I mean, it's a quality of life changer. And the fact that this is now happening for so many different conditions, particularly ones that are much more severe or detrimental than PKU, I just think that's absolutely fantastic for the patients with those conditions.
I don't know that I can beat Caitlin on that one, because that clearly is there. Lots of clinical trials and sort of things that we really had no idea about, whether it's mechanism wise, et cetera. So I think the technology, bioinformatics, et cetera, really remain exciting. I will say, however, the thing that's still most exciting for me is helping somebody. And that certainly comes out of treatments and clinical trials. But one of the things, I think, particularly with the pandemic, care coordination for somebody with a complex condition is a huge part. And while access and getting in the door is important, it's sort of the follow through on those things. So whether it's tomorrow morning, I do a Latinx clinic out at Bayview, one of the Hopkins hospitals, and we've developed a genetic assistant program here as part of another way of helping with workforce and all. And I now have a Spanish-speaking genetic assistant who comes with me to that clinic. And I will say, even though I think it was going well for the 3 years that I was doing it before she joined me, because I do not speak Spanish, and so was using a phone interpreter. It really, the quality of, I think, our service is much better, and people trust her. And some of the issues in care coordination where people may be worried about, not being documented, and so they don't pick up their child's hearing aids because they think maybe ICE is going to come and arrest them or something else is going to happen. Jen can I think really make a difference. And so we're not social workers, but again, we can address, I think, as a team, not only the diagnosis piece, but and things, testing the other family members, as well as trying to make sure the dad feels he can go pick up the hearing aids, or we can figure out some way to get the parents tested for things, or find out if they also have cystic kidney disease and hypertension. And again, I always say that it's best for a child's health to have healthy parents, and unfortunately, in many situations now it's hard for adults to get insurance, but we work hard on that. So for me, I think it's not only the science excitement, but the working with people and trying to help them access an increasingly complex world and system.
Excellent. So the next question is, how does a person who is trained as a medical geneticist get involved in public health efforts?
So I think, depending on what your interest is, every state, for example, has like a newborn screening program. And I think if you kind of know the leaders or reach out to typically they have like a technical advisory board, which is actually, I'm a patient advocate on Pennsylvania's technical advisory board for newborn screening. So you can reach out to these groups, and a lot of them, for example, at I believe it's quarterly meetings, they invite the public to attend. And so you could go to one of those, for example, or like Megan mentioned, like the NCC and the different advocacy groups, just reaching out to them. Depending on, what aspect of public health genetics you want to kind of be involved with. I think there's different avenues to go about that.
And I would concur. I would say also the support and advocacy groups for specific conditions are another place to learn, as well as connect. And again, there can be not only research, but service opportunities. So when we do these health fairs, for example, I typically would invite one of the or one or two of the organizations that are based here in Baltimore to share the table, so to speak, with me. So families, I mean, we had a very fun one at Behind Our Daily Bread, which is again a community-based organization in Baltimore that provides meals to homeless and service in many different ways, training, et cetera. And so we had the part where people are coming up to us and inquiring about family history or tell me more sort of thing. And she was asking about nosebleeds, and actually picked up two families who potentially had a condition called hereditary hemorrhagic telangiectasia and all. And this again was, in partnership with a student working with a nurse who was from the HHT Foundation. So I think that's another good advocate. And again, there are other sort of rotation opportunities potentially, as well as other parts of developing literature around particular conditions, et cetera, and reaching out at not necessarily going yourself to the church if you're but participating with health nurses at churches or synagogues or, other religious places or ways, again, if that's part of your own, background and interests.
Excellent. So the next question is, do you think that implementing computational tools has increased the advancements in genetics, or is it just part of the research?
It's a really good question. I think from a clinical aspect, I think that like computational tools maybe that have been used in terms of like molecular testing definitely has advanced the field. It's the reason there are diagnoses made now instead of being unclear about symptoms or a condition a patient might have. And I mean, the way that comes about is through testing it through a research basis before it's implemented in the clinical setting. So I believe it's yes, it has advanced genetics both from a research standpoint and also a clinical standpoint, definitely.
Yeah, no, I'll dive into that, maybe trying to understand the question a little bit better, just in terms of, I think there's other fields opening or other paths opening within careers in genetics, and you don't have to stay doing the same thing. I mean, I started out thinking I was going to be a math professor, and as I say, it was lonely after 2 years, and I wasn't as creative at that. And that was back when you carried cards, and as I say, these little Wang computers and phones, that were this big and all the rest of it. But I do think, what can happen is you can start out in an area and maybe be a generalist, but then you either find a disease or find a sort of technology. One thing, geneticists are generally very nice people and fun people to be with. Not that other disciplines are not. I'm married to an oncologist and who does palliative medicine as well, and he's fun and a nice person too. But I do think there are and things. I have a former colleague who's now writing for one of the large scientific journals, but she's really an expert in genetics, and decided for family and other reasons that seeing patients wasn't the thing to do, but just brought her expertise to that field. So I wouldn't say I've done the same thing for all these decades and all, but I guess the other piece, maybe a little bit of advice, I think saying yes to opportunities, sometimes even when you're not quite ready for them, would be something. Or when somebody has a good idea, don't immediately say no, or I can't, or that sort of thing. Stay a little bit open to that, because again, I don't think we have absolute predictions about the future. And as others have alluded in what they've said, the content of what we're doing, the tools we're using, have continued to evolve.
Absolutely. So the next question is, where do you see the field of public health and genetics going in the next few years, especially as the COVID-19 public health emergency is, quote unquote, ending?
Yeah, I think Joanne just touched on this a little bit. It's going to continue to evolve. We're going to see new genes identified. We're going to learn more about them, learn more about the conditions, see therapies being developed. I think it's going to continue to advance, maybe at a hopefully slightly faster pace, now that the pandemic is about ending here. So yeah, I think it's going to continue to move forward.
And again, I think that the challenge, and I remain, as I mentioned, enthusiastic and love what I do, but I do think the access question is huge. And again, not to but thinking of people having to re-enroll in Medicaid now, and what's going to happen to folks who have had insurance and now will not have insurance unless they get the help to get back on. And we were down to 8% uninsured in the country there during the pandemic, and people could get vaccines, et cetera. I mean, I guess my hope, coupled with the technology in advance, is we could figure out a way to share that more broadly. People obviously can benefit from education, having options, thinking about things in a supportive fashion. My own research has focused more on risk communication over the past more recent time, when back to red cell membranes and electrophoresis in the Japanese lab, et cetera. And I do think, again, the communication piece really matters for the development of trust, because some of the reluctance, I mean, you can choose what aspect of the pandemic didn't go as well as it might have, and all those are things from which we need to learn and listen. And genetics isn't, it's 3-syllable words. It falls off any, grade level screening for when you write something just by all of our multi-syllabic, words and everything else. We need to continue to work on trying to be more understandable, not over-promising, and access is just huge for people, because if, you can read about wonderful discoveries in the newspaper, but if you think, I can't get an appointment for a mammogram because I don't have insurance, that feels very distant and far away, and not a system to trust.
100%. So the next question is, can you please elaborate on genomic medicine and how it will be in the next 10 years?
So genomic medicine in terms of, for example, like enzyme replacement therapies are becoming available, or there is substrate reduction therapies, there is gene therapy that are being developed. So I would say there are many in clinical trials right now, and I think there are further ones kind of in the research arena that are still being studied. Without speaking about a specific condition, I would say they're also going to continue to advance. Again, just the kind of the research and the work needs to be done to further investigate these types of therapies with regards to genomic medicine, but I think they're going to continue to advance as well, and new therapies are going to continue to be developed, hopefully that again improve quality of life for a variety of conditions. I hope that answers your question.
Yeah, I guess I would add, we have conditions for which there really are enormous disparities in access and conditions. I mean, we have, some of the first really miraculous transplants for sickle cell disease. Had a wonderful conference about that recently. But again, that's not as accessible for a lot of people for a wide variety of reasons. And that, I think, is one of the challenges of genomic medicine, of how to, again, have it that it is not only for the most knowledgeable or the most educated or, living next to the city. I was recently looking over, because the cool thing about NIMAC, the C used to stand for collaborative, but it now stands for Virgin Islands and Puerto Rico, so for Caribbean. So no one believes that I went to the Virgin Islands on work, but it is true. And again, you see there where there are, Puerto Rico obviously is relatively populous, but the Virgin Islands has 1,200 births a year. So how do you have the workforce there? We're working on telehealth, other initiatives to see about having more genetic counselors who can be there, et cetera. But you just see enormous discrepancies across the country and territories and all. And I do think that means the promise of genomic medicine needs to be thoughtful about all. And that is, again, just, where we are politically, or where we are as a nation, looking at resources and more equitable distribution or access.
Yes, absolutely. And so this question is written for Dr. Bergertha, but I don't know, Dr. Bloom, if you have experience with this, so please jump in if you do. But the question is, Dr. Bergertha, can you talk more about your work with the Undiagnosed Disease Network?
Yes, well, I call Bill Gall. How's that? Just whether he spoke at our NIMAC conference. So he's the founding father, again, with a whole group of experts. So when the Undiagnosed Disease Network started, we had a protocol here. We call it Mendel, but it had a much longer title, and that was, again, to map diseases. And so there is now a network around the country of undiagnosed disease centers and all. But again, I think with the rare disease network, it's sort of expanding centers of excellence, et cetera. But The bottom line is I have referred probably over, since it started, probably 30 families to the Undiagnosed Disease Network. And again, the challenge is them getting them accepted and all, because part of it is there a phenotype? Is there a family history where there is the possibility of mapping a gene, or is it less likely to do that? And, you know, again, the NIH will devote or assign a fellow actually to a set of families or something. And, you know, is it going to, over somebody's year or two of work in the laboratory, likely to produce or find a new gene and cure? So I think there's a balance between what goes on now in all clinical genetic centers with the availability of whole exomes and whole genomes and all that, again, it can be a very good interaction with specific undiagnosed disease centers. But clearly, I think this is a job that makes you humble. And you, I mean, I end every visit with a patient saying I have homework to do. And again, when I started, you know, if you look something up, which meant going to the library and looking in the books and all, and you did that, you know, in the past 3 to 6 months, there wasn't really something that was going to come out in the meantime. And essentially, every person or family you see, you know, obviously there are ones that come in from newborn screening are relatively clear cut, but as Caitlin said, the therapies evolve. So you're doing new things, not that the disease has necessarily changed in its diagnosis, but how you treat it. And so maybe jumping around in answer to the specifics of your question, but I think, you know, you always need to stay humble in terms of second opinions and referring people out if you haven't been able to figure it out yourself. That's talking with your colleagues as well. But you also need to make people comfortable and support them in that referral process, et cetera. You know, people, I mean, Baltimore is a great place, but obviously reputations sometimes lag behind its greatness. How's that? And all, and it's the same for people coming from rural areas to NIH or to big cities, et cetera. So how do we, again, address rural folks and have it that they're potentially comfortable to coming and staying at NIH for a day or two or a week and all, but it is how we, you know, continue to make progress. It's just how to have people coming into those systems and undiagnosed disease networks at the same rates coming from very disparate backgrounds. I think that's something we need to continue to address.
Absolutely. Dr. Bloom, I don't know if you have experience with the undiagnosed disease networking, if you had anything to add, or I can move to the next question.
I don't know.
Okay. Oh, that is absolutely fine. Okay. So the next question is going back to computational and tools is, could you elaborate on how you think AI will have a role on in genetics and public health genetics, and how could ChatGPT help in genetics and public health genetics?
Oh, wow. That is a really good question. And I don't have a whole lot of experience with AI or ChatGPT. I know there's a big learning component to it, I believe, if I'm correct, and it can be utilized for analyzing like large data sets. So I think as we continue to kind of further genomic testing, molecular testing, I'm sure it could have a pretty significant role in, you know, working with large data sets like that, like different omics, metabolomics, proteomics, and things like that. So yeah, I think it could be a potentially really valuable tool.
And we because I'm involved in medical education here, we actually have done little trainings and, you know, use ChatGPT. And I will say it writes very good questions. And if you're pretty specific, you know, in what you're asking for, it's, you know, not necessarily better than Wikipedia at this stage to write, you know, if you give it directions about writing an essay. I mean, I think the challenges are going to be, it can also say the wrong things with great confidence. That's the other thing that we felt when we asked it to write things on the, you know, the basis of just giving it some clues and all. It will continue to improve. I listened to the testimony or part of the testimony of the company director yesterday. I do think that the biggest challenges are creating wrong information and being used, whether it's plagiarism or fabrications, or you choose. Public health school here has set up some additional rules. We still would consider that it's not part of doing your own work as a medical student. And also, I think at the educational level, there's a lot to be worked out. And again, some safeguards for people who don't have any filter on what's before them and believe anything that's out there. As I say, the little trial that we did with it as a team of educators at the medical school, where just it smacked of confidence in a way that if you happen to know something was wrong in it, or a term that made no sense whatsoever, that was fine, but it sounded confident if you didn't know that.
Absolutely. And I think if I'll jump into my perspective of, I don't know if this is where the technology will go, so please don't hold me to this, but I would love to see, back to an earlier point Dr. Bertha made about genomic literacy and making information accessible to a large array of people. I think that this could, if it's programmed the right way, if there are the safeguards in place, it would be great to see if we could leverage AI in that respect, because there is a lot of work that needs to be done to make tools accessible and information accessible. And that's a large part of public health in general, is health communication, and specifically public health genetics. So in an ideal world, if we're confident in the technology, I would love to see it be used in that aspect to help broaden understanding about genetics and genomics. And so we're only 5 minutes left. We have one question in the chat, but if you have any other burning questions, please put it in before we adjourn for today. But the last question so far is, what about personalized medicine and how much we have evolved in this field and how much this would help us in public health efforts?
Yeah, so I think personalized medicine also continues to kind of evolve. And so the way I sort of think about personalized medicine is like, maybe certain mutations are identified for a certain condition, and there's a certain therapy that works for these conditions versus the same condition, but a different mutation, for example. So I think, again, as we continue to advance the whole field of molecular testing in genetics, I think this will again continue to we'll have to continue to work at policy and advocacy for example, for coverage for the different therapeutics and different avenues for treating these conditions. So I think again this will continue to evolve, similar to other aspects in genetics and public health genetics.
And I may be trying to connect again the past two questions. I'll take as an example of where I think AI and ChatGPT, et cetera, can be very helpful, or probably pharmacogenomics. So you see, again, there's typically for me, there's something that have taken 40 years to change, but so I claim I was ahead of my time. But for things that we knew 20 years ago, I mean, that's sort of the usual span for it then to get applied in medicine or integrated in medicine, and that depends on early adopters. It unfortunately depends a lot on money and marketing and all the rest, and so some things get implemented that probably shouldn't have been implemented, and we have to track from those. But when you think of the complexity of pharmacogenomics and a little bit of this and a little bit of that, I do think that bioinformatics are really the answer to that. So it's not delivered in a way to a patient that they can't understand, or delivered to a primary care doc that they can't understand, or frankly doesn't take a geneticist another 2 hours to interpret, because yes, some of it is tools, but some is comparing this data set to that data set to this data set to that data set. So I think personalized medicine to advance and have it really be that it's personalized for a lot of people, not just people with a lot of money that can go to executive doctors or whatever you want to call that kind of concierge approach to things. It is going to require some more bioinformatic tools that can be accessible to people and trusted.
That's wonderful. And so we have just one more minute, but as we wrap up, is there either of you, is there anything burning or anything you want someone to take away from this discussion that you really want to make sure that people listening now live and recorded may need to know as they think about going into the field of genetics and or public health genetics?
I would just say again, with these opportunities that the ACMG and NCC together have put forward, consider being in a SIG, look at if you're interested in another particular, discipline, cardiogenetics or cancer genetics, et cetera. There are obviously other subgroups, organizations to address that, and then try to get some experience, whether it's through shadowing, attending things like this, doing rotations, capstones, et cetera, applying to opportunities that you find at other institutions, et cetera. I would say I've benefited from being in a variety of places over time. So that's my one little, if you're in the sort of pre-med or other places, which isn't to say Pennsylvania isn't a great place and you've gone to institutions. But I do think you learn that there's not only one right answer always to things, and that people can do things in different ways and they both can work.
Yeah, I agree 100%. I would add to that, have these discussions with your mentors, especially ones that you particularly trust or give you that time and attention, and provide the resources to help you achieve your goals and kind of head down that path that you're looking for. I think that was one of my most valuable resources was the mentors that I was very fortunate to have over the whole course of my career.
Wonderful. I think those are both excellent takeaways. And I just want to thank you both so much for this wonderful discussion. I think it was very helpful, and I've been in the field for a while now, but I even learned more tonight. So I appreciate you both joining, and thank you to everybody for your questions. They were excellent questions, and we're very happy to have you. As I said earlier, if you have any follow-up questions for myself about NCC, Public Health Genetics and Genomics Week, or for our speakers, my contact information will be available with the recording, so I will happily pass those along. And we encourage you. There are still 2 more days of Public Health Genetics and Genomics Week for this year. Please go to the website, phgw.org, to attend other events ranging from about population screening to newborn screening to policy. So we hope to see you there, and we just thank everyone for joining us tonight. Have a wonderful night. Thank you.
Take care.
Thanks.
Thank you both.